Okay, good afternoon, everyone. My name's Nicola Middlebrook. I am a senior lecturer at Manchester Metropolitan University, and I will be chairing this session. So we have all the speakers apart from one. There isn't Alan Rowlands in the room, is there? Ah, excellent. You are here. Brilliant. Alan, do you want to come up here to sit with Helen so she's not on her own? We have three speakers to start off with. Helen's doing two presentations, and then we will have a break for a Q&A, and then the other speakers will come up and we'll do the same thing again. Our first speaker, Joel, isn't here, but he has done a presentation, which is a video. So we'll be showing that one first and then moving on to Alan's presentation. So I will hand over to the tech guys to start Joel O'Sullivan's presentation.
Hi, my name is Joel O'Sullivan, and I'm pleased to present our work on the physiotherapy management of neurogenic thoracic outlet syndrome. Firstly, I'd just like to acknowledge my co-authors, Professor Jonathan Hill and Dr. Caroline Miller and Dr. Marcus Bateman. And a thanks to Keele University and the University Hospitals of Birmingham, my home trust, and also from the NIHR. So, neurogenic thoracic outlet syndrome, where we started really is that in a Cochrane review in 2014, it was termed one of the most controversial diagnoses in medicine. So, neurogenic thoracic outlet syndrome, or NTOS, is a dynamic positional compression of the brachial plexus, which can present with an array of symptoms, including neck, shoulder, and arm, pain, paresthesia, weakness, and this is generally exacerbated by repetitive overhead movements and could lead to significant functional disabilities. And actually, people with NTOS are known to have poorer quality of life and high disability scores with similar baseline scores to that of people with chronic heart failure and rotator cuff tears. There are three main areas of compression for neurogenic thoracic outlet syndrome, namely in the interscalene triangle, the costoclavicular space, and the subcoracoid space, or the pectoralis minor space. So why is NTOS so controversial and hard to research? Well, I think there's many reasons for this, but namely there's four different subgroups: neurogenic, arterial, vascular, and disputed, although we're trying to get away from the disputed term. There's a variety of clinical signs and symptoms, and clinically it's often deemed a diagnosis of exclusion. And previously there was a lack of a widely accepted diagnostic criteria. But pleasingly, in the last 10 years or so, the research in NTOS has been improving. There has been a development and publication of a clinical diagnostic criteria for NTOS. The Society of Vascular Surgeons in the States have also released some reporting standards so clinicians can discuss and talk about NTOS in the same way to allow studies to be able to be comparable in a better way. This clinical diagnostic criteria has been validated with patient-reported outcome measures. And then recently, there has been a couple of prospective studies using the clinical diagnostic criteria and the reporting standards. And in 2022, there was the first randomized clinical trial carried out in the Netherlands called the STOP NTOS trial, which looked at continued physiotherapy versus surgery for recurrent NTOS. So although the research base is steadily starting to improve, when it comes to physiotherapy and NTOS, although physio is deemed as the mainstay and the first line treatment for NTOS, the description of what actually physiotherapy involves, how long a patient should do it for, which patients will actually benefit from physio is really poorly described. And we just don't know what people who live with NTOS think is important in terms of their care. So this was a real gap in the market and in the literature base, which I was interested to kind of explore. So with this survey, we aim to do a cross-sectional survey to explore the experiences and opinions of therapy and medical professionals regarding the assessment, diagnosis, and physio management of NTOS. The methods we used was an online survey. We adhered to the Cherries checklist. It was distributed in a multimodal recruitment strategy, meaning we used Twitter, we used social media, we asked people to send it on to like-minded clinicians. The survey was active for 4 weeks and it targeted healthcare professionals with experience of treating NTOS, and it ended in May 2023. Ethical approval was granted by Keele, and the questions were a combination of closed, multi-choice and 5-point Likert scales with some free text options. As you'll see in the next slide, for ease of communication, when participants answered always or sometimes to a particular question, we combine this and refer to them hereafter as commonly. So looking at the characteristics of responders, 83% met the inclusion criteria, and we had 46 completed data sets. Just over 70% were therapists, either physios or OTs, and of the 30 medical professionals, 92% of them were surgeons. Nearly 85% of them worked in the NHS, and 41% stated they worked in a specialist multidisciplinary nerve unit. We had a decent geographical spread over the UK, vast majority being from England, but then as you can see we also had some from Scotland and Wales. Close to 60% said they had more than 10 years experience of treating and assessing NTOS, and about 55% said they see at least 1 to 2 patients with NTOS per month. So this is a visual Likert chart to display the data. So this is looking at the clinical assessment components for NTOS. So what would clinicians look at commonly when they're assessing somebody in clinic? So where something is dark green, it means they're saying they always do it. Light green is sometimes, amber is rarely, and red is never. And black is where the clinician said they're unaware. So as you can just really quickly visually see, there's in the first couple of rows, it looks like everybody's pretty much doing subjective histories. If you look into the middle of the chart, you might see in the surgeons there's a bit more red when it comes to vertebral mobilizations, first rib mobilizations, but it's a nice way to look at the data. If we look at this a different way, so as I said previously, we set a consensus threshold of 70% to state that something is commonly performed. So you can see things like subjective history, upper limb neurological screen, cervical range of motion, shoulder range of motion, some NTOS clinical tests, Adsons, Easts, postural assessment, upper limb strength and thoracic range of motion and upper limb tension test all reach the threshold of 70% for being commonly performed across the survey respondents. In terms of physiotherapy and NTOS, almost 3/4 of the responders indicated that these patients are triaged to highly specialist NTOS therapists or an experienced therapist within MSK. The reasons they justified this for was the overall clinical complexity of NTOS, the difficult to assess and the difficult to diagnose NTOS in general. And again, over 3/4 stated they had no treatment guidelines for NTOS. This is another visual Likert chart. This time, this is just the therapists that responded to this, because we were asking about the physiotherapy treatment modalities for NTOS. So again, if you look, almost everybody at the top row is green for advice and education, cervical and thoracic range of motions. Again, if you look 2/3 of the way down, there's a lot of red indicating that people are never or very rarely using acupuncture and braces. So this is just for the treatment. Again, same sort of chart to look at the consensus for treatment modalities. And again, I think that's relatively self-explanatory. So the main findings that we found from this survey, so in terms of the assessment components, hopefully quite reassuring, but 100% of people saying they were doing a comprehensive subjective assessment. The vast majority were doing range of motion of the neck, shoulder and thoracic spine. They were undertaking upper limb neurological screen, assessing the patient's understanding And in terms of the physiotherapy treatment modalities just involving the therapists, again, everybody was doing advice and education, providing a home exercise plan, and looking at range of motion exercises with some activity modifications. But you might have noticed that there seemed to be a less reliance on passive treatments such as acupuncture, manual therapy, and provision of braces. So in conclusion, 75% of clinicians triage NTOS to highly experienced therapists, citing overall clinical complexity as the reason. Again, 3/4 say they don't currently have treatment guidelines for NTOS, and the vast majority felt that more research into physio and NTOS would be beneficial. So clinicians perceive NTOS as a complex clinical condition lacking treatment guidelines. And although physiotherapy remains a mainstay in the current treatment pathways, the components of these treatment plans within the literature are heterogenic and lack comparison. And further research is warranted to try and improve the understanding of this. For more information on this particular study, it has now been published in the Journal of Vascular Societies, so please have a look for more detail. These are some of the references. In terms of the next steps, I'm really pleased to report now that this piece of work has allowed us to develop the impetus study, which has recently been awarded a NIHR grant for me to carry out some research. So this stands for Optimal Physiotherapy for Neurogenic Thoracic Outlet Syndrome. And during this project plan, phase 1 will be a systematic review of physiotherapy interventions for NTOS. Phase 2 will be a consensus exercise using nominal group techniques involving key stakeholders to try and agree a blended physiotherapy intervention for NTOS. And then finally, we're going to test this intervention in a multi-centre pilot and feasibility RCT with a nested qualitative study. So I know that's a lot of information, but I'll be starting this NIHR fellowship in October this year. So if you are watching or reading and you're interested in NTOS, maybe to be part of the expert consensus group, or perhaps you work at an NHS site where you see a lot of NTOS and you'd like to find out a little bit more, please scan the QR code or feel free to contact me for some more information. I realise my face might be covering up the email address here, so it's joel.o'sullivan@uhb.nhs.uk. But thank you for listening.
Thank you very much for Joel for doing that presentation. So I now want to introduce Alan Rowlands. He is an advanced clinical practitioner in Birmingham Community NHS Trust.
Good afternoon, everyone. My name's Alan Rowlands. I work as an APP for Birmingham Community Healthcare Trust in the orthopaedic triage service. And today I want to spend a bit of time sharing with you my experience at working on the creation of orthopaedic pathways with cross-cover ortho pathway. So in 2020, a multidisciplinary team consisting of APPs, GPs, radiologists, rheumatologists, and orthopaedic consultants worked collaboratively to co-create evidence-based digital orthopaedic pathways to be used in primary care. This was done with continual reference to best practice guidance. And these pathways were then embedded within the cross-cover ortho pathway platform, which is essentially a user-friendly digital clinical decision and diagnosis support tool. The overarching aim here was to try and support primary care clinicians, so GPs and FCPs, with being able to direct patient care swiftly at the first point of contact. My involvement was very much in the upper limb, so I was lead editor for the shoulder group and the elbow group and co-editor for the wrist and hand group. But it's worthy of noting that there was also other groups working on lower limb pathways and spinal pathways. So the intention here was to try and reduce the variability in management of patients presenting with MSK upper limb conditions, to try and reduce the creation of unnecessary GP and FCP follow-up appointments, to reduce unnecessary requesting of further investigations, inappropriate further investigations, and to avoid inappropriate referrals that would slow down patient care, and of course to reduce GP consultation time. So obviously the pathways are huge, so I just want to give you a bit of a snapshot of what the software looks like. So as the clinician works their way through what are referred to as nodes, they look very much like a PowerPoint slide. As they work from node to node, each node provides clear, salient clinical information that would help the clinician work towards a diagnosis. Eventually, it will lead to an end node, either with clear management advice or advice regarding onward referral to another service. But often, the clinician will be led to a shared decision-making node that will look a little bit like this one here for frozen shoulder. So this would then provide the GP or FCP with supporting information to allow them to involve the patient in the decision-making process regarding their future care. As they work from node to node through the pathway with their patient, you'll notice on the far-hand side of the screen there that the decision-making process is collated, and this can serve multiple purposes. So the first is it can be part of the GP's clinical notes, but additionally, if and when this patient is referred on to another service, that information becomes visible to the receiving service. So that would provide a nice, clear clinical rationale for referral, which in turn should reduce triaging demands on the receiving service. So my role was very much with the content creation, the clinical content for the pathway, but in the background, the ICS conducted an OSCE-style study in the summer of 2022, and this was very much about justifying continuation of the project. So ultimately, 19 GPs conducted assessments across 8 different case scenarios, half obviously using ortho pathway, the other half using normal traditional GP assessment. An analysis of 152 case scenarios suggested that on average, the use of ortho pathway would reduce consultation time by 4 minutes and 18 seconds. Use of ortho pathway yielded a 96% adherence to best practice outcome versus only 27% with usual GP care. With usual GP assessment, we saw the generation of unnecessary follow-ups in 50% of cases and requesting of unnecessary or untimely further investigations in 34% of cases. And as you can see, this was compared with only 3% and 5% respectively when using ortho pathway. So from September of last year, there was a feasibility study across 2 GP practices in the south of Birmingham. And we've now had live usage across 12 practices since February of 2024. In the summer of this year, the chief editors for each body part were tasked with doing a small audit. So for me, that was looking at shoulder referrals coming into the orthopedic triage service in BCHC via normal GP referral. So it allowed me to look at the referral itself and the subsequent clinical letters documenting their care within our service, and then retrospectively look at whether care could have been improved had ortho pathway been implemented at the first point of contact. And we saw that in 60% of cases, we could have improved first point of contact care, and it would have actually reduced our referrals by 47.5% in that small audit. Throughout this process since we went live in February of 2024, there's been continued monitoring of the pathway. So the chief editor for each body part meets fortnightly with the clinical program manager and the plan care commissioning support officer to monitor usage. I think we're up to about 800 uses now. Look at the analytics that are provided by CrossCover, respond to feedback from general practice, and where appropriate, make edits to the pathway in order to try and improve efficiency and usability. In terms of my role, which has been very much in terms of creating and editing the content that's gone into the project, that's now going on hold from this month onwards. whilst it goes through procurement. So hopefully it gets funded and rolled out on a larger scale, and Keele are already embarking on a larger study looking at the effectiveness of this. Thank you for listening.
Thank you very much, Helen. So I'm going to introduce our next speaker, who is Helen Tunnicliffe. So Helen's actually got two presentations on different topics, so she will be going from one then on to the other without me interrupting her. Okay, thank you, Helen.
Thank you. So I am Helen Tunnicliffe. So I am a consultant and an advanced practice physiotherapist from Leicester. So first presentation today, I'm presenting the outcomes of a consultant physiotherapy upper limb clinic, reducing the patient journey through early access to specialist care. So after the pandemic, I'm sure it's a common problem that we saw that wait times for orthopaedic elective clinics were very long. And we noticed locally that only 13% in upper limb clinics were proceeding to surgery. So in response to this, we set up a consultant physiotherapy-led upper limb clinic based at the National Centre of Sports and Exercise Medicine, as shown here, which is a purpose-built NHS building with state-of-the-art clinic rooms. The appointment time was set long enough to ensure that patients engage in the assessment, feel listened to, and ability to discuss options. So this provides an ability to provide expert assessment, appropriately image, deliver vital education and openly discuss treatment options and deliver care on the day. Mentorship from surgeons also ensure the ability to list patients that do require surgery, so preventing unnecessarily delays if there is a surgical target. Initially, I triaged the waiting list and pulled patients who did not appear to have a surgical target or were poor surgical candidates due to comorbidities or lifestyle factors. I also created a route in directly from physiotherapy, and now there is a direct route from GPs as an intermediate care service. So the main aims of the clinic are to reduce the wait from referral to treatment for patients, improve the quality care of outcomes and patient satisfaction. So the data presented is of the first 300 patients who came through the clinic. 99.7 patients had treatment delivered on the day. 92.6% of these was definitive treatment. So 7.4% did proceed to surgery, but due to the agreed mentorship with the surgeons, I was able to directly list from the clinic, so no additional appointment needed. All received expert physiotherapy advice or programme or a progression on the day. Other treatments include steroid injections or splints. And as seen on the graphs for shoulders, the Oxford Shoulder Score, the OSS, was used pre-treatment and at follow-up, at a scale of 48, and a significant improvement is considered over 6, and patients had a mean of 17.8 improvement. For elbows and hands at the bottom, the quick dash was used pre and post, pre-treatment and at follow-up, which is a scale of 100, and a significant improvement is over 15.91, and a mean improvement was 35.6. Wait times for clinic appointments were reduced by a mean of 3.8 months and 27 weeks for physiotherapy, which I think is even worse now. Cost savings include GP appointments, unnecessary scans or duplication of appointment for treatment. 161 patients did not require any additional imaging or investigations. Patients requiring ongoing physiotherapy were booked in at a hospital of their choice, and a small caseload managed in-house for specialist treatment. Of the first 300 patients, the caseload mix was 205 shoulders, 60 hands and 35 elbows. So patient satisfaction data was extremely positive, as demonstrated in the following graphs, with 100% of patients agreeing or strongly agreeing that the appointment was helpful and they were satisfied with the information that they were given about their condition. Comments included that it was helpful, informative, and to be seen personally was the key. Feedback from physios was also positive, including it's good to have a dialogue and be able to clinically reason, help to learn, as well as effectively get access to treatment for patients. So the intermediate care clinic is ideally managed by a physiotherapist, and the outcomes have shown an effective way to manage upper limb patients without a surgical target. The patient journey is reduced, and this reduces the burden on secondary care. And the key is the ability to deliver that right treatment at the point of access. Assessment. So this was the first 100 patients were published in the International Journal of Advancing Practice earlier this year. Thank you. Next talk. So this talk is introducing the how long is the arm immobilized after a conservatively managed displaced proximal humerus fracture, and does early mobilization affect complication rates? A systematic review. So proximal humerus fractures are a common injury, and many trials have led to an increasing trend not to operate on displaced fractures. Conservative management involves a period of rest in a sling followed by physiotherapy. It's an extremely painful injury, and being immobilized in a sling stops function and can lead to loss of independence and hospitalization. The aim of this systematic review was to provide a narrative synthesis to look at how long immobilization is used in the literature, types of slings, when and how exercises are introduced, and if complications may be associated with these components. So the review was registered with Prospero, and a systematic research of the literature through databases Medline, Embase, CINAL and Cochrane was undertaken. 3,059 studies were screened, 159 for full text review, and 39 studies were included. 36 of these were small-scale single-centre studies. This included a total cohort of 2,664 patients with a mean age of 70.9. The results showed that time in sling had a wide range from 1 to 6 weeks. The majority, 16 studies, which was a cohort of 1,576 patients, were immobilised for 2 to 4 weeks. 20 studies did not report the sling type, but of those that did, 12 different sling types were reported. And these could be grouped into low support, such as a collar and cuff, which will allow more freedom of movement, median support, such as a broad arm sling where the elbow is incorporated, or a high support where the arm is bound to the body, so really quite restrictive in movement. For exercises, there was a trend to introduce passive and pendular exercises first and progress onto active assisted and active. Only 2 studies allowed passive or pendular immediately. The majority delayed until 2 to 4 weeks. Active exercises were commenced at 4 weeks for the majority, but some delayed until as late as 12 weeks. Many studies only allowed supervised exercises in the early weeks, and they would be bringing patients in 5 times a week to perform those exercises. Isometric and stretching exercises were only described in 1 study and were delayed until after 6 weeks. There was limited reporting of strengthening, but again, delayed until over 6 weeks. No studies reported individualising regimes according to patient factors. There was poor reporting of comorbidities and lifestyle factors. Compliance with sling use and adherence to exercises are major factors that are not addressed in the current literature. There was no correlation found between complication rates with sling type, immobilisation period, or timing and dose. Complication rates were low compared to surgical studies, being at 9.1% compared to over 30% in some studies. The main complications that may be associated with early sling removal, such as non-union, malunion, or secondary displacement, again showed no correlation with complications. So in conclusion, there is vast variation of how long patients were immobilised for, types of slings used, when and how exercises were introduced and progressed. No relationship was found between complications and these components, but there is uncertainty in patient care pathways. Research is required to help reduce the uncertainty with potential impact factors to improve the patient recovery and outcomes, reduce costs to the NHS, and enabling equity of care to patients. So I'm currently undertaking a doctoral clinical academic fellowship funded by the NHR to develop a model of care for these patients. If you are interested in participating in focus groups leading to consensus work, please can you scan the QR code, and this will just be a contact details form, and then once I'm ready to that stage, I'll be in touch. Thank you.
Thank you very much, Helen. So we're going to take a break now from the presentations and do some question and answers. So I invite any questions from the room or online.
Thanks, that's really interesting. It's a question for Helen. The first presentation, was that sort of in place of or as well as an MSK kind of CAT service in your region? 'Cause
We don't have that service in our region.
okay, so it's a sort of similar model then, really, in terms of that early physiotherapy,
Yeah,
advanced assessment and keeping the surgery away from the surgeons.
yeah. It's having the
Sorry,
ability
Lorraine.
to give the package so that
Yeah.
if they do need an injection,
Yeah.
if they need imaging, we can do that in the one setting.
Yeah,
Our normal route, you go through to an MSK triage and they go through to physiotherapy, or they go through to a secondary care clinic. And within physiotherapy, you don't have access to imaging or injections as it stands.
right, okay.
Thank you. That question is for Helen. Actually, in your research, did you look at what happened to those patients who have to go to see the secondary care? What sort of waiting times they have encountered, considering they waited for you and you decided that no, that's not something we're gonna look at?
So because of, I've worked for many decades in the secondary care clinic. So with that mentorship with the surgeons, I could list directly. So I didn't have to have that. That was one of the concerns when we were setting up. We don't want to have that delay to wait for an appointment where they may see me again. So, it was the duplication of the appointments not needed. I could list directly from that clinic. So they went straight onto a waiting list for surgery.
Any more questions? I got one online. No. We'll come to you after.
Hi, this is a question for Alan about the reduced GP appointment times. Did you ask patients what they thought about their GP spending less time with them? Since that's often people complain, about how short GP appointments are.
No, it's the short answer. That OSCE study was done obviously with patient actors as well. So that has not been looked at, nor the issues around the potential for the clinician to be looking at a screen and following.
I was going to ask about that too.
Like almost like an algorithm and so on. So it's clearly efficient in terms of time, but whether that's good for patient rapport is really questionable. But it seems to be in the early sort of data suggesting that it's quicker and getting the patient to the right place at the right time. But I'm not sure it necessarily will help with that side of it.
I think that the bigger Keel trial is doing a lot of qualitative exploration that involves patients as well as clinicians. So that's probably going to do that.
Okay, we have a question online.
So this is a question from online for Helen. What recommendations would you suggest for an older, frail patient with multimorbidity who's unable to tolerate a sling, especially if the orthopaedic consultant has strictly advised its use?
I can probably answer that in 3 years' time when I've completed the DECA. This is where I think individualisation of care needs looking at. It is primarily a frailty fracture. They quite heavily dependent on using their upper limbs for transferring, mobilising, which is why these patients end up as hospitalised. So yes, it is the patient needs looking at, and unfortunately dictating that the patient has to follow it. It's not always practical.
Thank you.
Oh, we have a question over there.
This one is for Ellen. Just wondering, the content of that flow chart or that software or the sheet you have designed, have you checked its validity or reliability, that what it's measuring or meant to measure, exactly measuring it?
So just so I can clarify that question, were you referencing the slide that showed the...
No, the whole program which gives the information, the pathways and everything. So does that tool itself been validated first before going to the clinics?
So I hope I'm answering this correctly. So essentially the pathway that's been created, of which I showed you a small snapshot of that, which is a few nodes, a few slides, is based on a number of things. So it's because it was shoulder and elbow predominantly, it's using the best pathway, it's using nice guidance, local pathways in secondary care and primary care, and pulling together a pathway that was agreed upon by multiple stakeholders, including obviously, you know, advanced practice physios, radiologists, rheumatologists, GPs, and orthopedic consultants. So from that perspective, we feel it's in keeping with the evidence base, but it has not been researched in that way. However, as Damien alluded to earlier, that is happening now. It started to happen through Keel's larger study. At the moment, any of the data I quoted today was largely essentially small feasibility studies to justify the continuation of the project. But now it goes on hold, and it's going to be hopefully researched more thoroughly and rolled out.
I have one question just for both of you, really. So obviously in two very different ways, you've tried to implement something new into a service, which we also often is quite a challenge. So can you reflect on any kind of major challenges that you've come across trying to get the tool into practice or with the new service at all?
I think the biggest challenge for us was the way the project sort of spiraled and got bigger and bigger. So as you can imagine, it started off as a pathway, and then suddenly, and it's hard to show it in 5 minutes and with a few nodes, but it kind of then became almost an assessment tool. It became about speed. It became about efficiency. It also wanted to serve as part of the GP's notes, because GPs, if they're going to buy into anything, and that's another headache, is getting them to use it, it had to be efficient for them in terms of not being an additional thing they had to do as well as their notes, had to sort of serve that purpose as well. So I think the biggest headaches were really centered around it spiraling and where to stop with that, and where to say enough's enough. This is not it can't be everything. Yeah. And the last thing is getting GPs and FCPs in different ways on board with using it. Anecdotally, we've seen a bit of reservation from GPs to use it, and FCPs alike, really. Some might have viewed it almost a bit patronising, because it was telling them what to do, and that sort of seemed to sort of take them away from their normal assessment.
Lovely, thank you very much. Just check there's no more questions before we move on. Excellent. Well, should we do a round of applause for our first set of speakers? So can I ask the second round of speakers to come sit on the stage, and then I will introduce the first speaker. Okay, so our first speaker of the second bit of the session is Cynthia Sri K7. I got it right. I was so nervous about doing that. I wanted to make sure I got it correct. Okay, so I will hand over to Cynthia, and she will take through her presentation.
So good afternoon, everyone, and thank you for joining today. I'm Cynthia Srikesavan, and I'm a Senior Research Fellow at the University of Exeter and University of Oxford. I'm going to talk about how we implemented an online hand exercise program or a digital hand exercise program in NHS therapy practice. Before I move on, I would like to acknowledge my team, Professor Sally Lamb and Dr. Esther Williamson. And I would also like to thank the funding resources, the people with RA, and also the organizations who helped us in this implementation work. So some of you might be aware already, like the SARA hand exercise program. So it's a personalized hand exercise program, and it's a progressive exercise program specifically designed for people with rheumatoid arthritis affecting the hands. So it is a 12-week hand exercise program having an initial education session followed by 5 exercise sessions with a therapist. And this is packaged with other behavioral strategies that is going to help people to use do the exercises on a regular and a long-term basis. So we did a trial a few years before, and it was a large multi-center trial. And the SARA program was compared with the usual care. And what we found was the SARA program actually led to improvements in hand function, double than that of the people who received the usual NHS care. And it was also found to safe to deliver, and it was also a good value for NHS money. So based on the evidence that we had from this large trial, the NICE guidelines is now recommending the SARA hand exercise program for people with rheumatoid arthritis. So just to give you a bit of background of what the SARA exercises would look like. So it is just a simple and straightforward exercise package. So you have a total of 11 exercises, 7 exercises typically focusing on improving the flexibility of the hand, wrist, and the whole arm. And also 4 strength exercises focusing on improving the strength of hand and wrist muscles. In terms of the behavioral strategies, so we were using a different variety of strategies, such as example as setting treatment goals and also planning the when and where to do the exercises, and also monitoring the exercises on a regular basis by giving exercise diaries to patients, and also building their confidence by exploring what are their barriers and facilitators for doing the exercises regularly and giving them solutions. So this was done in close collaboration, a shared collaboration between the therapist and the patient during the therapy sessions. So after this trial, we did an implementation again of this face-to-face SARA program in regular settings. And what we found was the clinical outcomes were really improving as exactly in the SARA clinical trial. But what was challenging was therapists was not able to provide the recommended 6 therapy sessions with their patients. So in some sites, we had therapists giving only able to give 1 or 2 sessions, which actually led to the development of the online version of the SARA exercise program itself, which can be directly accessed by the patient. So this is to reduce the therapist contact time and also to empower the patients so they learn by themselves by using this digital resource. So, but still it needed work. We want to know how this could actually be implemented in NHS practice. So we co-created this online resource with patients. We did a needs assessment. We worked on iterations, and then we did a small scale, a small level of study in a closed and controlled environment. And what we found was it was feasible and it was acceptable for patients, but still we don't know how it would work in an NHS setting. So that was the purpose of this work. So we wanted to see how this could be delivered in NHS settings, whether it is going to be acceptable, feasible, and whether it is going to create some impact in terms of the clinical outcomes, and whether patients would have positive experiences with the program, because this is the first time we are using an online version, a digital version of the hand exercise program, which was completely a new concept for us. So what we did was, so we contacted the occupational therapists and the physiotherapists who were regularly giving the SARA exercise program to their patients. And then they were invited through various channels, including the British Association of Hand Therapists e-bulletin. And they were given all the materials required to deliver the online program. And so this SARA program is suitable for people having hand function problems due to rheumatoid arthritis, and they should be in a stable drug treatment or no treatment at all. And we had some additional criteria, having access to a computer device or a mobile device, and also access to internet, because given the nature of the online program. So patients who signed up for this evaluation, so they were given access to a 4-week online SARA program, and this was hosted on the FutureLearn. So you might be aware of it's one of the world's largest MOOC learning platform. And only people who signed up in this evaluation were able to access the program, so it was not publicly available. And the program was delivered through a variety of activities, such as in the form of text, in the form of exercise videos, instructional videos, patient testimonials, and also some discussion forums where people could actually share their experiences about having the rheumatoid arthritis symptoms and also what they thought about the online program itself. And these were all moderated by the SARA implementation team. And patients were also able to download all the materials they wanted to read or they wanted to print out, for example, exercise diaries, exercise sheets, everything. So one important thing I want to highlight here is like patients didn't do it on their own. So we asked therapists to have to follow the patients in case they had any questions about their exercises or dosage or any flare-up of symptoms. So patients did this program under the therapist support and guidance. And we also asked therapists to collect self-reports on pain and hand function before they started the online program and also after 6 weeks later, which was approximately the discharge time in many of the NHS settings. And we also follow them up after 4 months through telephone. So we collected the pain and hand function at baseline 6 weeks later and also after 4 months. These are some of the screenshots from the Future Learn SARA online program. So you can see here the different formats of pages. So you have the exercise videos, you have the exercise instructions, and you have an editable exercise diary that they can download and they can fill it or they can save it in their computer. And also some simple scales to ask about how they've been doing, how they've been feeling with their confidence in learning the exercises, doing the exercises. So that kind of simple questions for patients. And in terms of how the patients that were enrolled is like, we had 18 therapy departments from 15 NHS trusts in England, Scotland, and Wales. And we had around 78 people who were signed up for this evaluation. But finally, we had 65 people who were included in the analysis, 13 withdrew for various reasons. And out of the 65, we had around 46 people who actually enrolled to the program. They registered to the program, but remaining 19, they didn't actually register with the program. So this is just a quick snapshot of what the characteristics of the people who didn't register and who registered. So you can see here majority were females, and you can see there was the moderate level of disability, which was measured by the hand function subscale of Michigan's Hand Outcomes Questionnaire. So it was rated from 0 to 100, so more the score, better the hand function. So you can see here there was a moderate level of disability in both groups, and pain was also almost similarly comparable. So patients who didn't register, it was quite interesting to know that people who didn't register, actually, they were slightly younger. They were having a better hand function compared to the people who actually registered. And they were having rheumatoid arthritis for a shorter time compared to the people who actually registered. And some of the reasons we collected why they didn't actually register in spite of signing up is like they had other health issues and they didn't have time. And actually, they changed their mind and they preferred face-to-face sessions with a therapist rather than doing an online mode. And some were also having issues logging in to the program through the mobile or having connectivity issues with the internet. So this is the table on the clinical outcomes we collected. So if you see the middle, the central, the bigger column here, so the hand function of the patients who provided the baseline data and also the follow-up data at 4 months. The reason we collected 4 months follow-up was to just compare with the SARA trial, because it was the same exact time frame that we used in the trial, main trial. So you can see here there was a difference of around 8.9 points on the Michigan's hand function subscale, which was completely similar to what we found in the main trial. And pain didn't improve, and there was no adverse effects, so which means that the exercises didn't cause any flare-up or any discomfort in this population. And in terms of the patient feedback, majority of them said that they felt they improved at both time points of the 6 weeks time point and also the follow-up. And 91% of them were continuing the exercises at 4 months, which was very encouraging. And they were doing at least a minimum of 3 to 4 times or even daily, like of all these people, the 91% of these people. We also asked therapists to actually evaluate whether the patients have been doing the exercises correctly when they came for the discharge session. So we gave them a simple scale and we asked them to check each and every SARA exercise, whether it has been done correctly or whether they needed some support or whether even given support, they didn't do it correctly. So if you can see here, the success rate was around 80%. People were doing it correctly, which means that people were having the ability to learn the exercises on their own and do it correctly and execute it correctly. And there were a few instances where people needed some extra support, and there were 3 patients who actually had even struggling to do it correctly in spite of giving support. And in comparison to the main trial, there were two specific exercises that was challenging to do, the wrist backward bends and also the knuckle bends, which was challenging for them. Again, it was comparable. So we also quickly did a content analysis of the patient comments in the discussion forum throughout the week. So it was a 4-week program. So people put their comments a week after week, and we did an analysis of those comments. And what we understood was the key themes that came up was, in week 1, people were actually sharing their experiences of how difficult it was to to do the activities of daily living because of rheumatoid arthritis. And just because signing up, they wanted to see they were hoping to see some benefits of doing this program, which was clearly indicating that. And this is one quote from a 60-year-old male who wanted to see some benefits of registering with the program and doing it. And in week 2, like in week 1, we introduced the flexibility exercises, and in week 2, we slowly introduced the strength exercises, so which patients started practicing it, and they found it challenging to do just because it was a kind of add up to the already like the 7 set of flexibility exercises they were doing. So they found it a little bit challenging, but they still managed to continue doing them. And by week 3, what the trend we saw was people were managing to master the program, and they were trying to fit in the exercises, all the SARA exercises in their daily routine, and they're kind of mastering the program. So that is the theme that came out very well. And by week 4, there was a clear indication the SARA program was beneficial to them. So they did see some clear improvements in their dexterity or hand function or even the grip strength, and they were giving some comments on how it improved and when it is being done continuously. So to conclude, what we found out was the clinical outcomes of this implementation work in around 18 therapy departments in 65 patients with rheumatoid arthritis. So we found that the outcomes, the improvements in clinical outcomes are comparable to the SARA main trial, and we had a positive and encouraging feedback from patients. And what we found was these findings just add up to the already existing therapeutic benefits of the SARA program. And we are continuing to develop partnerships with the clinicians, with the RA charity organizations, and also people with RA for even more wider implementation in the NHS. So if you're actually managing people with rheumatoid arthritis and would like to provide this online SARA resource for your patients as part of to support your treatment delivery, please do so. Scan this QR code, and it will take you to a form where you can actually fill in your details and confirm that you'll be providing this online resource under your care and support. And we'll be sending you a security code that you can share with your patients so they can register with the program. So they need that access code to register with the program. So this is to make sure that we have the settings ready, that the patients are under your care. And I would also like to take this opportunity to introduce to this to this QR code as well, where we have a resource library of different interventions that have already been tested in large multi-center trials. And all these are evidence-based interventions for different populations like low back pain, neurogenic claudication, and shoulder pain, shoulder rotator cuff disorders, and people who had surgery after breast cancer. So have a look and sign up, and these are all free for you. So just sign up, and right now we have 2 courses that are actually issuing the certificates after you complete the courses. So just have a look and feel free to register yourself. Thank you very much for listening.
Thank you very much, Cynthia, for being able to very concisely put so much of all that work into that 10 minutes presentation. Okay, so I'm going to introduce our next speaker now, who is Hayley Carter, and she's going to be talking a little bit about some of her PhD work.
Thanks very much. Thanks for the introduction. So my name's Hayley. I'm an MSK physio from Derby, and I'm going to be presenting to you some work that's been part of my clinical doctoral research fellowship, looking to develop a shared decision-making intervention for patients who've ruptured their ACL, and also some clinical recommendations for practice. So this work was funded by Health Education England and NIHR. So as we're all aware, ACL ruptures are pretty common. There's around 200,000 every year in the UK, although we don't have standard injury surveillance across the country, so it is difficult to define a particular number. There's been 3 randomised controlled trials to date, which have compared the 2 main treatment options of surgery and rehabilitation, which, although they've all concluded varying results, what we can draw from all 3 of them is that there isn't a one-size-fits-all approach for patients who've ruptured their ACL. And a study that preceded this one, where we interviewed patients across the treatment pathway, so before surgery and after surgery, revealed that treatment decision-making can be really challenging. And so what we wanted to do was develop an intervention to support treatment decision-making. And also something else we found from the qualitative study was that there was a large variation in practice, not just between centres, but also between clinicians within the same centre. So we wanted to determine some evidence-based recommendations for practice. So we did this through an online nominal group technique using the 70% agreement threshold for consensus. And this involved patients and stakeholders who were either voters in the consensus meetings or facilitated the group discussion. And so we had orthopaedic surgeons, occupational therapists, physiotherapists, patients with experience of the condition, and also therapy managers. And then the facilitators included a clinical academic expert who was the chief investigator of the UK randomised controlled trial ACL SNAP, an academic supervisor, and also patients who've been involved in the wider study and its setup. And the methodology kind of followed a combination of voting outside of meetings that were then discussed in meetings. So there was an iteration over a period of time where we had the ability to share independently and anonymously, and then share together. And then these were voted on using that 70% threshold with lots of iterations before they were finalised. And so the shared decision-making intervention, you can follow the QR code on the top left hand of the screen and go to supplementary files 5 and 6, but encompasses 2 different components. So the first component is an information leaflet, which is a 10-page booklet, which gives the patient an overview of what their ACL rupture means to them from an anatomy perspective, but also covers treatment options and outcomes based on the literature. And the idea is that that's for the patient to be used before the shared decision-making consultation with a clinician. And then the second component is an option grid, which is a 2-sided sheet of A4 paper, directly comparing surgery and rehabilitation for 11 frequently asked questions. And the idea is that it's kind of a short, sharp answer that can be discussed then between a patient and a clinician during a consultation. And then the clinical recommendations, again, there's QR code at the top of the screen. It's the same one as the one from before, but this is for supplementary file 7. The recommendations cover 5 different topics of advice and education, exercise guidance, delivery methods for treatment, outcome measures for use, and also shared decision-making components for a conversation where you're not using the formal shared decision-making intervention. And the idea is that these can support standardisation of care across services, but can also be personalised to the patient sat in front of you. So the point of the consensus study was to determine what should be considered as very important to be included in consultations, but also what might be important that you could tailor in and out based on that patient sat in front of you. And so you can read the full paper if you go to the QR code in the yellow box on the right-hand side of the screen. And what we hope is that the recommendations can support service planning and evaluation and setup to enable a little bit of more standardisation across our services. And the shared decision-making intervention has been implemented in a feasibility study where we've been looking at acceptability, indicators of effectiveness, and implementation factors. And you can keep up to date with the results on our website, currently writing that up, so keep your eyes peeled. You can message me on Twitter or email me or come and find me if you've got any questions. Thank you very much for listening, and to acknowledge all of the incredible people that have helped me do this research, and thank you all very much for listening.
Great. Thank you very much, Hayley. So we're now on to Julie. So this is Julie Berry, who is just finished her PhD. I promised I'd say that, and she's going to present some of her work from her recently completed PhD.
Thank you. Good afternoon. Thank you for listening. I'm Julie Berry. I'm a postdoctoral research fellow at Doncaster and Bassett Teaching Hospitals. There are no conflicts of interest to declare, and just to acknowledge my funders, which was through the NIHR as part of an NIHR clinical doctoral research fellowship. And just to start off by saying this information is relevant to all musculoskeletal conditions, but within my PhD, I focused on rotator cuff disorders as a test case. Rotator cuff disorders pose a significant burden and healthcare challenge, and our current treatments offer only modest treatment benefits and often poor long-term outcomes for patients. And there's growing evidence of an association between key modifiable health behaviours such as smoking, being overweight, physical inactivity, and the onset and persistence of rotator cuff disorders. And this is proposed primarily now through systemic inflammatory mechanisms, that triggers a pro-inflammatory response in local tissues. And so these lifestyle factors are potentially important treatment targets, yet consideration of these lifestyle factors are not routinely integrated into physiotherapy practice. So in some previous work, I co-designed a physiotherapy-supported treatment approach, which we've called the combined approach, and that integrates a brief behaviour change intervention, which is essentially an evidence-based structured conversation to target the lifestyle factors. And I haven't got time to go into the intervention development work. It's been previously presented, but just to say what the combined approach is, it's a multi-level intervention that targets both the patient-level behaviour change with respect to those lifestyle factors, but also targets the healthcare professional behaviour change in terms of implementing this into practice. So this particular feasibility study was, we wanted to know whether it was feasible to implement the combined approach into routine physiotherapy consultations. And this was a mixed methods, non-randomised feasibility study. Feasibility outcomes were fidelity, recruitment and acceptability. And we also wanted to look at what factors affected the implementation amongst the physiotherapists of the combined approach into practice. So we recruited both physiotherapists and patients across 4 NHS trusts. The physiotherapists received the implementation toolkit, which included the training package, and then they delivered the combined approach to patients within 2 routine consultations. In terms of the implementation factors for the physiotherapists, we used a survey which was based on the theoretical domains framework, which is a framework of behaviour change theories. And this was done at baseline, which was straight after the training and the implementation toolkit. And then they repeated that after delivery of the combined approach in practice. For fidelity, so this is looking at whether the intervention was delivered as intended, and we used audio recordings of the consultation, and for the patient experience we used semi-structured interviews. So the quantitative data was summarised descriptively, and the interviews were analysed using a table-based method, and that was for the purpose of rapid analysis. So in terms of the results, we recruited 8 physiotherapists and 17 patients. And of the patients, 71% of those patients had one or more of those identified lifestyle factors. Fidelity was good, so 82% of the components were delivered as intended. And then when we look at the, from the survey, we looked at the factors that were influencing implementation of the combined approach for the physiotherapists, and barriers were identified, and these were around beliefs about capability. So this was about the confidence of the physiotherapist to deliver this in practice, particularly if the patients weren't motivated or there was limited time. Goals, so this was around relative importance and other competing priorities that took precedence over the combined approach. Behaviour regulation, so if this was easy to deliver and if this was automatic. Environmental context and resources, which was essentially time. And then emotion, so were the physiotherapists nervous about delivering this? Did it add to the stress within that consultation? And the facilitators that we identified were that the physiotherapists felt after the training and the implementation toolkit, they did have the knowledge and skills to deliver the combined approach. Positively, they did feel it was part of their role and identity. They were optimistic about delivering it, and they had positive beliefs about consequences. So they felt like this was a good idea. They didn't feel it would be affect therapeutic alliance, and they could see the benefit of this to patients. And then, interestingly, when they repeated the second survey, in terms of the barriers, the environmental context and resources and emotions improved after the experience of delivering that, and they were no longer considered a barrier. So with practice and experience, those factors did improve. In terms of the acceptability to patients, it was acceptable, and it did initiate health behaviour change as part of their management. And I haven't got time to go into all the themes that were developed as part of that, but the headlines are that patients did expect these conversations as part of a physiotherapy consultation. They do want to have those conversations, particularly if it helps with the management of the condition that they're coming with. And that some patients were surprised about the links between the lifestyle factors and specifically their rotator cuff disorder. And I think moving forward, it's really important that patients fully understand the role that these factors play in the management of their shoulder condition, and that support to understand the systemic inflammatory mechanisms as part of that to support long-term behaviour change. So in conclusion, the combined approach was feasible in terms of the fidelity, the recruitment and acceptability. The factors that we identified that were still barriers on the repeat of that survey, we need to look at those and how we might be able to target those within that implementation toolkit moving forwards. But essentially, it's deliverable, it can be integrated alongside usual care, and most importantly, patients like this and do want this approach within their consultations. So the combined approach is now ready for testing in a main randomised trial to look at whether this improves outcomes for patients and more broadly musculoskeletal conditions. And just to acknowledge my PhD supervisory team as part of this and to say thank you to all the patients and physiotherapists that took part in the study. Thank you.
Thank you very much, Julie. We're on to our last and final speaker, David Hamilton. I will leave you to introduce yourself and your presentation. Thank you.
Afternoon, everyone. Thanks for bearing with us. Last talk in the session. I'll try and keep it nice and light and quick. So apologies for a very long title. It's actually quite a simple little story. This is I'm a reader at Glasgow Cali. This is a paper from my group. So we're going to talk a little bit about stem cells, but not too much. There's no great revision for this talk. Mechanotransduction is a word that basically means a mechanical stimulus is transferred into a biochemical response, a cellular response. And that's how tendons heal. You know, I'm going to guess there's 40 odd physios in this room. We'll all argue how you rehab a tendon. We'll all agree that you load it. It's fairly straightforward stuff. It's what we all teach. Tendon injuries do have historically poor outcomes in terms of recovery, and there's various tools and interventions that don't work, frankly. The latest great hope is musculoskeletal stem cells. So MSCs that we can inject into the tendon to improve the tendon healing, hopefully. It's a immature but evolving field. There's been quite a lot of trials, new interventions. We always like to try that in randomized control trials. So there's quite a few trials out there. And we very simply thought, well, what are the results of these trials and what is the loading protocol that goes along with the stem cell injection? It really was that simple. And so we've performed a systematic review of that. I'm not going into any great depth. The systematic review is, as you'd expect, we did it properly, we pre-registered it, we did the full search, used the grade criterias, and then we also used the tidier framework to grade the quality of the reporting of the rehabilitation. I'm sure most physios, I think, are aware of tidier, but just very briefly, the Equator network that provide all the guidelines for reporting, so your concert statement, your Prisma flowchart, etc. They also produce the tidier checklist, which is a quality control checklist for how well you report an intervention in a clinical trial. And we've applied it to physiotherapy in this context. So very quickly, we scanned the literature and we ended up, as inevitably systematic reviews do, with a small number of papers we could include. But this is randomized control trials of a stem cell therapeutic to a human tendon versus a control. Now, the control could be platelet-rich plasma, it could be placebo, whether they're different or not is a separate talk perhaps, it could be a corticosteroid injection. The point is it's a stem cell versus not a stem cell in a head-to-head randomized control trial. Get my slides to progress, apologies. So we found, 8 small randomized control trials, numbers of between 13 and 82. These were specifically designed to evaluate the effect of the intervention. This is the important bit from this talk. Randomized trials designed to evaluate the efficacy of the stem cell injection in tendon healing. The outcome is tendon healing. The trials themselves, 5 were in rotator cuff, 1 glutes, 1 patellar, and 1 Achilles tendinopathy site. So a reasonable gamut, but again, it's a small sample. Of the RCTs, 4 said the interventions worked to some degree. There's a positive p-value in there. 4 by definition that they didn't. the outcomes weren't great, frankly. There were short-term outcomes, long-term effects didn't work very well. They're not great trials, let's be blunt. And when you look at the risk of bias of them, the risk of bias is high in all the clinical trials. They're not of great quality. But what is of interesting, hopefully for this little talk, is the adherence to the tidier guidelines for the rehabilitation reporting that surely would go alongside an injection of a stem cell, whose whole purpose is to rehabilitate and improve a tendon to a functional outcome. And it turns out it's terrible. So the tidier guidelines are out of 12. There's 12 different domains. And if you look across physiotherapy, you get about 8 out of 12 as your typical analysis of what's going on. So if you look at cardiac rehab, you look at osteoarthritis of the hip, etc. When you pull the data, you'll see most trials are reporting 8 of 12 domains roughly. Well, we had a median score here of just 2.5 domains. And the domains aren't hard. Some of them are very, very straightforward. You do have a defined intervention that you have a name for. That's one domain. And the answer to that was no. We'll look at it in a little bit more detail in a second. But one trial reported 6 of 12 domains. 3 trials reported 0 of 12 domains. This is just describing the rehab. Reproducibility of intervention. So we have one, I won't even say good, because 6 out of 12 is actually not very good at all from a tidier perspective, but we have 3 with 0. So just to present it differently, here are the tidier domains. We have 3 or 4 trials at most covering any one domain. And this reflects to dosages, intervention prescription, reporting where the intervention took place, reporting how many times the intervention happened. It's all really basic stuff. And also what's massively missing here are 4 domains that weren't touched at all. And these relate to adherence and to evaluation of whether the intervention worked or not, or whether there was a modification of the intervention or not. Just completely conspicuous in its absence, essentially. So, cut a potentially long story short, we've looked to see if there was a standardized reporting or reasonable reporting of the loading parameters in rehabilitation that go alongside a tendon stem cell intervention to improve tendon health. And the answer is no. Obviously, that's not great at face value, but it really raises the question as to, these are clinical trials, these are expensive things to do. A lot of time and effort and thought has gone into setting up this clinical trial to improve tendon outcome, yet we're not understanding how we load the tendon to measure said outcome. And so we've no idea as to the efficacy of these interventions because no one's talked to the physios. No one's thought to consult the physios in this intervention, which is an increasingly prevalent part of MSK care. I think I'll wind up at that. Thank you.
Thank you very much. So I will open the floor to any questions I have either here or online.
Thank you all for your presentations. David, this one's for you. I feel like my thinking's evolved over the years. So I used to think tendon loading was important, less so now, I think. Because when you look at the research literature, clinical outcomes are so unremarkable, and there's no difference between different loading programs. So does that have any implications on the conclusions you might draw from your work?
It's a fair point. I don't think it has an impact on the conclusions here in that the counterpoint then is to say, well, in that case, injecting a stem cell will work and we don't need to do anything else. There's no need for rehab, there's no need for a sort of graded return. And I think, so I guess the analogy I would give, I drive a diesel car. I know I shouldn't, I need to change it for a hybrid, but I still drive an old diesel car. And you've got to look at and I've been told I need to put this certain particulate into the fuel tank to improve the engine performance. So I did. And that's like my stem cell injection. If I've stuck it in the fuel tank, well, it's not done anything yet. It's not got to the engine. It's not been active. Mechanotransduction is the process by which you activate this stem cell injection, whether it's MSCs, ASCs, whatever it is. So only by driving the car am I going to get this particulate from the fuel tank into the engine where it needs to improve the cylinder head. But I could do that by driving 1 mile a day for 500 days, or I could go for a big motorway journey, which is obviously a better thing for my car. But it's going to make a difference as to how we do it. And I think it's just the same with the rehab. We inject this, it's like, for me, it's like the PRP story. You inject the intervention with the hope of a fix, and then we don't document what happens afterwards, and then at 6 months we see whether it worked or not. And there's just a massive hole in our knowledge. And you're right, I'm not going to tell you what intervention you should do, because I'm not entirely sure how to rehab a tendon at all, and it only gets more confusing. But I think we should probably be doing something, or at least quantifying what we are or aren't doing.
Thank you.
Oh, we have a question online.
Thank you. And just to say, you've had a lot of online support with people saying, well done. So just to share that with you, as obviously you won't be able to see that. This is a question for Cynthia. Did steroid therapy or other pain medication management have any impact on the clinical outcome?
Actually, in this implementation work, we didn't look into the role of steroid injection, and I'm not sure whether we did that so in the main trial that was conducted 10 years plus before. So I don't think so. It was more focused on exercise versus the usual care, where you have a single session with your therapist covering mainly the patient education and simple exercises. So they're not individualized. Well, SARA program is individualized and progressive.
Thank you.
Hi, just a question for David. I'm just curious as to what's next. Do you plan to run a proper randomised control trial and collect all the data that you need?
It's interesting. And so no, because all the interventions are different. All these different MSc interventions are totally different, and they're actually very well defined in the protocols. I think what we'd like to do maybe is think about some consensus guidelines for rehabilitation alongside trials of therapeutic interventions, about reporting guidelines that I think is much more a sort of physio thing we could get involved in, and maybe just set some parameters for how we might improve this situation going forwards.
Thank you. Have we any more questions here on the... No, I do have a question. So I've got two questions actually, but I'll start with Hayley. So Hayley, obviously your intervention that you've developed, what's the kind of next plan? What's the kind of future thing that you're now looking at?
Yeah, thanks. So we've implemented it in a small feasibility study just to understand how it's been accepted amongst patients and clinicians. It's a mixed methods feasibility study. We've collected some quantitative data to understand implementation factors and indicators of effectiveness, and done interviews with patients and clinicians to kind of support that. So currently writing that up, so stay tuned. Thank you.
So is the plan then to take it forward once you've got the results of that feasibility study?
I mean, hopefully that'd be great.
Lovely. And then, Julie, obviously, I know you said it was ready for that RCT. So the key things, is there anything in particular you're going to be changing? So I know obviously you went through the kind of barriers. Is there any reflections on that kind of process of what would be a good thing to kind of move forward with that RCT?
Okay, yeah, so we did. We also did a dissemination event to some stakeholders that were involved throughout the development work at the end, and I think there were some key things that came out of that. I think one is that the systems and structures and processes within an organisation were barriers to delivery of the combined approach. So I think particularly we have the templates and the way we ask questions in a certain way. So we need to look more at organisational level. So we looked very much at the barriers at the clinician level, but we haven't really addressed organisational barriers. So looking at those systems and processes. And the other thing that came up was around maybe some key champions, looking at organisational culture that's a potential barrier for rolling that out further, so that we can train more people within the NHS setting for a future trial.
Lovely, thank you very much. So I will just double check there's no other comments, questions at all. Well, I'd first like to say well done to all the speakers. It's been a really fascinating session. I really thoroughly enjoyed chairing you all, and well done for all the work you've done. Thank you very much to you as well for the engagement. So I think just one final applause for all our speakers today.